For the past 2 years, I have been doing research in Belgium, and I'm now here to talk to you about the latest research that I have been doing. It's about facial scanning in orthodontics, mainly about how it can help for orthodontic diagnosis. Since the 3D facial scanning technology became available, its popularity has rapidly increased. This is mainly due to its non-invasive and non-ionizing imaging technique, which allow a safe and comfortable capture of the facial soft tissues. This category of instrument relies on the simultaneous work of small digital cameras and a low-intensity laser beam that has been shown to cause no risk to the patient's eyes. So while rotating around the patient's head, as you can see in the video, the small cameras will record the colors of the face, while the laser scanner will capture the surface texture. Then the colors will be stitched on the surface texture to give the final reconstruction that can be seen in 3 dimensions. Sorry. I will show you. So here's the virtual reconstruction of the face. This is a phantom head. It's just used here for illustration purposes. The aim of our study was to evaluate the applicability of the 3D facial scanning in orthodontic diagnosis, thus to try and mimic as much as possible the clinical orthodontic analysis. In our study, we compared the 3D facial scans to the classical 2D photographs that are usually taken for orthodontics analysis. The sample consisted of 30 Caucasians, aged between 25 and 50 years, with no dentofacial malformations whatsoever. To these subjects, we took 2D pictures with a classical digital camera and 3D facial scans with a 3D imaging device. So 3 classical photographs were taken for each of the patients, of the subjects, 2 of which are non-smiling, 1 frontal and 1 lateral, and the last one is a frontal smiling. This setting has been done to imitate as much as possible the routinely taken photographs for orthodontics diagnosis. To match these 3 photographs, we had to take 2 facial scans, one of which smiling patient and the second one non-smiling. 3 dentists with maxillofacial radiology background were gathered as qualified observers and trained to place specific landmarks on the subjects' faces. 4 paired landmarks were placed on the frontal images, and 7 single landmarks were placed on the lateral ones. The decision to place frontal landmarks, paired landmarks on frontal images and single mid-sagittal landmarks on sagittal images was done for higher precision. In total, 15 facial landmarks were placed twice by the 3 observers on each of the pictures of the 30 subjects. I will show you here how the landmarks has been placed on the virtual reconstructions in 3 dimensions. So we're placing the paired landmarks, and now the single landmarks. So you can see we can rotate the face and zoom in, out. Okay. So here we're done placing the landmarks, and this is the final face with all the landmarks needed. So the landmarks were used to do objective and subjective analysis. Let's start with the objective part, or the quantitative part of our research. So it mainly consisted of linear measurements on the frontal images and angular measurements on the lateral ones. Because of the inter-individual variability between faces, our linear measurements were transformed and used as facial proportions. to evaluate the facial harmony rather than simple distances between points. We took a reference, which is clinical anthropometric measurements out of the literature, and we compared our 2D and 3D data to it. So I've quickly covered the objective part. I will talk to you about the subjective one. So the subjective analysis consisted of a questionnaire that has been filled in by 14 observers. The questionnaire was included two parts. The first part was analyzing 2D and 3D reconstructions placed next to each other. So each observer had to sit and answer questions related to the face, like for instance the facial form in 2D separately and in 3D separately, and then we had to see if their answers matched. And the second part of the questionnaire, they had to say how confident they were about each of the answers that they given. So for our results, the linear ratios showed that the proportions linking the three facial regions were closer in 3 dimensions to the clinical standard, which means that the intercanthal distance relatively to the nasal width and the nasal width relatively to the width of the mouth were better seen in 3D than in 2D. For the angular measurements, there was no significant difference, so 3D was at least as good as 2D. For the questionnaire, the observers showed a substantial confidence in 3D. In fact, in 67% of the cases, they were as confident about their answers about the 3D pictures as they were about 2D. There was, however, a slightly bigger confidence about the 2D pictures, which can be explained by the fact that the 3D is still relatively new, so observers are still not very confident when analyzing them. The observers agreed better in 3D concerning the lip step, so the lips relationship, and the chin posture, which means that for the future, it could be a good thing to use the 3D to analyze the lower third of the face rather than the 2D. So in conclusion, and based on our results, the facial lower third was mainly better seen in 3D, which is good for orthodontic analysis. The laser scanning has been shown to be at least as precise as the manual methods, so measuring directly the distances on the patient's face. However, it still has some limitations that are worth mentioning, like for instance the long scanning time, especially when compared to the stereophotogrammetry, which is also a non-invasive and non-ionizing imaging technique, but that's not based on laser. So this long scanning time will induce motion artifacts, which makes this technique less advantageous to use for children or agitated patients, for instance. Also, another limitation is the not sufficiently big field of view, which will limit the applicability of measurements involving edge landmarks, as you can see here. So the lower part of the chin is cut, and there's voids evident around the head, the hair. So when using a 3D software, there's these advantages of being able to zoom in and out and rotate in 3 dimensions. Also, if placing landmarks, we can indefinitely place and remove the landmarks very easily. But also, when combined to the CBCT, the facial scanning has the potential of giving the hard tissue, soft tissue relationship, and that's by simply adjusting the contrast and the intensity of the facial soft tissue. We can then see the underlying bone. This is very important because we can then, for instance, see the tooth-lip relationship, or, if needed, measure the thickness of the soft tissue at the subnasal point, labial area, or chin. So, taking it a step further, instead of still taking soft tissue photographs and hard tissue imaging separately, our aim would be to combine this classical two-step procedure into one-step procedure where the facial scanning is combined to a CBCT. Thus, the patient only goes to one place, to one machine, and in one exposure, you have the patient with you on the computer, even when the patient is not there anymore. Thank you.
Okay, thank you for the nice lecture. Questions from the audience? Okay, I have a question. These cases are generally, we're talking orthodontics. So they will definitely have ionizing, penetrating radiation, such as cone beam CTs. And cone beam CTs nowadays, and yeah, I've noticed you're using Planmeca, which is a very powerful company in cone beam CTs. You can achieve the same results for facial scanning using the cone beam CTs, the soft tissue window of it, and you can achieve both.
No, because the soft tissue, when you see it on the CBCT, is not as precise as when you see it when doing also a facial scanning.
Even with the new Planmeca machine that they have? Because I saw the results. They were pretty impressive.
Yeah. It's always better to use the facial scanning combined with the CBCT. There's no reason why you wouldn't.
What about the 3D cameras? Are they better than the laser scanning?
It's a different technique.
Yeah, but I mean about details, because you showed us some limitations concerning the height. You have still a frame or a window that you can work with. So in, for example, prognathic cases, class 3, skeletal class 3s, sometimes it's pretty difficult to use, right?
Yeah.
Okay. Other questions from the audience? Okay, thank you. So.